Africa and the UK, who has a large practice in Johannesburg with over 8,000 patients, very deep experience in HIV and HIV medicine. And he's going to be speaking to us on growing older with HIV from a clinical pharmacology perspective.
Assalamu alaikum. Bismillahirrahmanirrahim. First of all, I would like to thank CIPLA for sponsoring this talk. And unfortunately, we've got very little time, so we're going to have to rush through a very, very important topic. Now, this is a very important message I want to put out, first of all, is that at the moment, the people over the age of 50 is increasing rapidly with HIV in the world. And it's not only because the people are getting older with HIV, people are acquiring HIV at the age of 50 upwards. And the other important thing to remember, and this is the latest statistics, is that by 2030, which is inshallah in 6 years' time, there will be, the people living HIV, 70% of the people living will be over the age of 50. So we are getting a very old population with HIV. And of course, as you get older, all the diseases associated with getting old is present: hypertension, diabetes, renal disease, bone disease, neurocognitive, and menopause. So we need to understand the pharmacology that goes on when you are getting older. And this is the very simple slide, and it shows you what happens. You get an increase in body fat. And as a result of increasing body fat, you will have your lipophilic drugs being distributed much more widely, and the clearance will be affected. You have a decrease in body water, so your hydrophilic, your water-soluble drugs become more toxic. Your kidney function decreases as you get older. Your EGFR decreases. And of course, your drug metabolism in the cytochrome P450, which is the most important enzyme system in the liver, their function decreases as you get older. Now, this is the important thing, is that 50 higher prevalence compared to non-infected, that is hypertension in HIV is much higher than in the non-infected. But this is the most important slide, is that greater than 50 years, more than 50% of it will have hypertension. This is very important. And the mechanism of hypertension, I don't have to go through it, is chronic inflammation is the most important thing, and lipodystrophy, which is when you get this deposition of body fat, especially in the abdominal, that will be one of the causes. Now, it's very important because everybody in South Africa uses tenofovir as first-line treatment. And this is one thing you need to be aware of, is when you are using tenofovir in a hypertensive patient, you have the problem of renal. Okay? Patients with hypertension cannot just be monitored once a year when they come for their CD4 and their viral load. They need to be monitored much more often when it comes to renal function. Because almost all the regimen, including TAF regimen, which you've all been taught are extremely safe in renal failure, is all rubbish. Okay? TAF is tenofovir. How does tenofovir cause damage to the kidney? It damages the mitochondria of the tubules. Okay? And it doesn't matter if it is in the form of TDF or is in the form of TAF. It is still tenofovir. And this is the one thing you need to be 100% sure that you need to be aware. Yes, in TAF, there is less tenofovir, but it doesn't mean it is a little bit safer, but not safe. And if you have a hypertensive patient, the best therapy is dual therapy. Okay? And this is something that if you have a fully suppressed patient, you know your patient very well, you should be switching these patients where there is going to be no drug that is going to affect that kidney. You need that kidney. Okay? And this has just been published. Okay, in 2024, is there a role for two-drug therapy in Africa? And the answer is yes. And we just came back from a meeting 2 weeks ago in Munich, where the two-drug therapy, especially the ones with dolutegravir and lamivudine, was being pushed as the correct two-drug therapy. The reason is when you become resistant to lamivudine, you knock out the virus. So you're not giving monotherapy with dolutegravir. In fact, they found that this drug combination is extremely powerful. Okay, so you need to start switching your mind and saying, can I make these patients' life better? Now, diabetes, lots of reasons why you get diabetes, again, chronic inflammation. And then I put here certain ARBs, PIs, we know, protease inhibitors, without a doubt, can cause diabetes. But the most important thing is your DTG, okay, which we use, all of us are using. There are some studies that says it may increase the blood glucose by 10%, especially in African patients, but other studies discount. So just be aware of that, okay? And then there's very important thing is the monitoring of what is diabetes. HbA1c is still very important, but HbA1c with certain ARBs is a problem. And also you need to look at that full blood count. If there's macrocytic anemia, your HbA1c will give, because you get a bigger red blood cell, it will give you a false picture. And the same if you have abacavir as your drug, okay? Because you've had renal issues, you put patients on abacavir, it can affect HbA1c. Just be aware of that. Drug interactions, dolutegravir and metformin. Now, the package insert says you cannot use dolutegravir with metformin dose more than 1,000 milligrams per day, okay? But I can tell you here in front of all of you that you can go up to 850, okay? So just be aware of that. We can, but the medical aids and all the people that monitor say it's for you to monitor because they can get a hypoglycemic episode, okay? So this is the important drug interaction. Now, this thing about using Ozempic, because people are now becoming fatter, and all these drugs like tenofovir with DTG, TAC with DTG, everything is becoming a major issue, and everybody's gaining weight, and everybody's jumping, let's give Ozempic as well. It's become a big thing, okay? And this is one of the biggest problems. The pharmaceutical industry is enjoying this, and you need to be aware of this. Rather look after your patient, make sure they're not taking drugs that is making them gain weight, that is doing this thing instead of just adding another cost to their lives, okay? But this is becoming a big fact. In fact, there's a big study taking place in Johannesburg at the moment on using Ozempic in patients with this. Oh, sorry. Right. Again, anything, remember we are monitoring renal function. Tenofovir is the issue, okay? Now, the kidney. I'm not going to, I have to say that to you people, because the one thing I hate is this use of NSAIDs. You guys love using NSAIDs. Everybody gets a Voltaren injection, and you give it to all your TLD patients, okay? And this is the biggest cause of renal problem. Please let us stop this practice. I have to beg you that this one injection, I have seen that can put a patient into renal failure. Okay? So be aware. When you're using acyclovir, for example, when you people have got herpes, you need to be aware, monitor that patient's kidney. Look at it a month down the line, because with tenofovir, it can cause problems. Please, this drug, that atazanavir, which is available for the treatment when it is so-called failed TLD regime, please don't use it. It is banned everywhere in the world except in Africa. We use atazanavir. The correct protease inhibitor to use is darunavir, not atazanavir. Be aware, everybody gets Bactrim. Everyone with HIV gets. I've never used Bactrim except when I have PJP. Okay, I never use it prophylactically, because at the end of the day, the important thing is to get that CD4 up, the viral load up, and not worry about, because this drug causes renal tubular acidosis, and it's a major problem when you got tenofovir there. Okay, and again, I told you about the attack. Just be aware of that. Okay, if you have renal issues, please think very seriously about dual therapy. I'm not going to carry on with bone, we don't have time. The important thing is here is this neurocognitive disorder, and I want to bring to your attention, you may be suppressed, completely undetectable virus in your blood, but in the brain, it's a different compartment. Okay? In fact, I had a very senior judge of the Supreme Court that came to me one afternoon and told me, I've forgotten, I can't write anymore. I can't write any judgments anymore. I just can't do it. And he was being followed up every time, fully suppressed. When we admitted him in the neuro ward, did his CSF, he had 1 million copies of virus in his blood. In his brain, not in his blood. His blood was undetected. You get this compartment syndrome. Okay? So just be aware of that. If people start forgetting, if people start having issues neurologically, you may have a compartment syndrome. Okay? And then you have to go to drugs which we don't use anymore, which is nevirapine, AZT. Okay? These penetrate the brains very well and they work very well. In fact, this judge actually went back to the bench. He was given AZT and nevirapine. Menopause. I really have to finish off with this because this is a major issue. Most women are developing menopause much earlier when they have HIV. And the important thing is that we need to, a lot of the women get HIV, but with all of people is that you love giving multivitamins. It is a big thing, let's give all multivitamins, everybody with HIV. I don't know where is this fixation from, to give multivitamins. Okay, now remember, multivitamins bind your dolutegravir. If you are going to use it, don't use it at the same time. Because they bind the drug, you will get a blip in your viral load. Okay? You need to space them apart. But seriously think, do you really need multivitamins? Okay? There are no studies. People tell them to eat nutrition. Why do they need to swallow a tablet? You're just making the drug industry very rich. But maybe they'll sponsor me again and I'll come here. Please, the important thing that I want to put to you, guys, please, is that when you pick up that pen, this is the most powerful weapon we have as doctors. We can either make a patient better, we can make a patient sick, and we can even kill a patient. So please think before you write. And especially when you have tenofovir, when you have diabetes, hypertension, you have all these comorbidities. Please, 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 please. And if you don't, please just consult one of us that knows this thing. Thank you very much.